Welcome back to ECGenius, and in this lesson, we'll be tackling common arrhythmias. Let's start off by talking about premature beats. One of the simplest ones being a premature atrial contraction, or a PAC. In a PAC, you have an electrical impulse that is generated somewhere in the atria outside of the SA node, usually from an irritable foci. For example, it could originate from an area in the left atria. On an EKG strip, what we would see is a P wave that comes sooner than we expect and looks different from the other P waves in the recording. So here we have all of these positive P waves that look pretty similar and are evenly spaced out. And then we have this P wave here, which is our PAC. The wave looks different because it comes from a different location, and it comes earlier because it beats the SA node pacing. After a PAC, you typically still get normal depolarization of the ventricles, so you have a normal appearing QRS complex and T wave. After a PAC, the SA node typically takes control back and you continue having normal P waves with even spacing. Similarly, you can have a premature ventricular contraction, or a PVC. In this case, the electrical impulse that is generated by an irritable foci somewhere in the ventricles. When this happens, and you look at an EKG strip, what you see is a large QRS complex that is wide as well and is not preceded by a P wave. So here, this is our PVC. This irritable foci beats out the P wave and depolarizes the ventricles prematurely. Again, like with a PAC, afterwards the SA node takes control of the rhythm back. One of the most common arrhythmias that you will encounter is atrial fibrillation. In atrial fibrillation, you have many different areas of the atria that are irritable foci and continuously shoot off impulses. When looking at an EKG strip, what we end up with is the classic irregularly irregular rhythm. What this means is we don't have any visible P waves, and our QRS complexes seem to come randomly with significantly varying intervals. This is because as these different foci shoot off electrical impulses, they are randomly able to make it through the AV node. The AV node typically does a pretty good job of limiting the amount of impulses that go through, but when you have so many of these going off at the same time, you eventually get some of them that are able to go through and depolarize the ventricles. Since this happens randomly, we get the classic irregularly irregular rhythm that you would see on an EKG strip. Here, let's discuss atrial flutter. In patients with atrial flutter, there's typically a re-entry circuit that develops around the tricuspid valve. This occurs because the tissue within the cavo-tricuspid isthmus, which is the region in between the inferior vena cava and the tricuspid valve, is a little different from the surrounding tissue, and that predisposes it to depolarizing and repolarizing differently, and thus creating a potential circuit. What this reentry circuit does is loops around at a faster rate than the SA node is able to fire, and so you can potentially get these depolarizations moving through the AV node and causing a supraventricular tachycardia. So what we see on an EKG strip of atrial flutter are these sawtooth-like waves and no discrete visible P waves. So again, we have these repetitive waves that are caused by the repetitive re-entry circuit that we see here. And then every once in a while, they're able to make it through the AV node and depolarize the ventricles. So sometimes if you have a patient with SVT and you give them adenosine, which is a nodal blocking agent, you might be able to reveal underlying atrial flutter. Here, let's talk about Wolff-Parkinson-White syndrome. Patients with WPW have an accessory pathway somewhere within their heart's conduction system. So what ends up happening is they have normal firing of the SA node and depolarization of the atria. Then, however, this wave of depolarization is able to bypass the AV node via the accessory pathway. And then they get premature depolarization of part of their ventricle. Afterwards, the conduction continues normally through the bundles and you get depolarization of the rest of the ventricle. It can be very important to recognize WPW on an EKG because if a person with WPW is administered a nodal blocking agent, such as a beta blocker, they're at risk of developing severe tachycardia. So let's say they're giving a nodal blocker that halts conduction through the AV node. What ends up happening is this accessory pathway is still open and you get the wave of depolarization moving this way, and then it'll work its way backwards up the bundle back into the atria and cause a re-entry circuit. And this re-entry circuit can lead to the severe episodes of tachycardia. Now let's see what WPW looks like on an EKG. The criteria for WPW would be a short PR interval. And again, this happens because you get that premature beginning of ventricular depolarization. And similarly, you would see a widened QRS for the same reason. And then you would see the classic delta wave on the EKG. The delta wave is this slurring upwards of the QRS complex, which is caused, again, by that early beginning of depolarization of part of the ventricle. Here we see an example of monomorphic ventricular tachycardia. We know it's ventricular in origin because of the wide QRS complexes, and we know it's monomorphic because they all look the same. Ventricular tachycardia is usually a result of a re-entry circuit around a scar after myocardial infarction. But in some cases, it can also be caused by an irritable foci somewhere within the ventricles. On the other hand, here we have an example of polymorphic VTAC. We know it's ventricular because of the wide QRS complexes, and it's polymorphic because all of these different waves look a little bit different. Polymorphic VTAC tends to rise secondary to electrolyte abnormalities. And this example here is actually torsade de pointe, or twisting of the points. So it looks like a ribbon that is twisting around a central line here and just going back and forth. Torsade de pointe commonly arises in patients who have prolonged QT intervals and is a very serious arrhythmia because it can eventually lead to ventricular fibrillation. And finally, we have ventricular fibrillation. Similarly to atrial fibrillation, what happens here is you have multiple irritable foci within the ventricles that are going off in a random, uncoordinated fashion. So what we end up seeing on an EKG in a patient with VFib is a complete mess. There's no discernible waves, and it's just this sort of wiggling of the strip. And this sort of correlates with what VFib is, which is just twitching of the ventricles and no actual sufficient contraction.